Okay, now let's learn about atrial fibrillation. Atrial fibrillation is the most common sustained arrhythmia in adults, and it occurs more common in men than in women. What are the risk factors for atrial fibrillation? So we have various risk factors like increasing age, they should have either diabetes, should be either diabetic, hypertension, or coronary artery disease, heart failure, CKD, or OSA. So these are the possible risk factors they might have, and symptoms they might have palpitation, dyspnea, fatigue. They might be asymptomatic too. So what are the precipitating factors? So they might have hypothyroidism. They would have had a binge of alcohol. They might have suffered an MI. They might have had a pulmonary embolism. They might have undergone a cardiac surgery. They might have had pericarditis. And what are the consequences of this? They may develop heart failure due to ineffective stroke volume. They may develop stroke. They might have cognitive decline. Or depression. So what are the clinical features? Clinical features, as you have just seen, they might have features of heart failure. They might have, if you just check their pulse, it will be irregularly irregular. Pulse volume will be variable. And they'll have pulse deficit. What about their JVP? They'll have absent A waves due to ineffective atrial contraction. Then what about the BP? Patients with AF, you'll have to do something called duplicate measurement. That is, you should take an average of 3 BP readings and take the average of those 3 BP readings to get the actual BP. And if you, this is by auscultatory method, and if you do an ambulatory method, you will have an overestimation of a diastolic BP. Your systolic BP will be fairly reasonable, accurate. So how will you diagnose an atrial fibrillation via ECG? So in a patient with atrial fibrillation, if you take an ECG, what you will notice? You will note irregular RR interval. Irregular RR interval, plus you'll have absent A waves. Plus what else will you see? Sorry, absent P waves. You won't have your distinctive P waves. And what is called a clinical atrial fibrillation. So clinical atrial fibrillation is the patient can be either symptomatic or non-symptomatic, but they'll have a ECG documentation of an AF. What is subclinical AF? So this is an atrial activity detected by your implantable cardiac devices or your pacemaker. And when you have a diagnosis of subclinical cardiac failure, clinical atrial fibrillation, then you'll have to support the diagnosis with an ECG. So you have a patient with subclinical AF and you take an ECG, and that patient might have an AF, atrial fibrillation, or atrial flutter. So, or atrial tachycardia. So what is this AHRE? That is atrial high rate response events. So any atrial activity more than 175 per minute lasting for a duration of more than or equal to 5 to 6 minutes. So your ICDs or your pacemakers might report this atrial high rate events as AHREs, and when you get a patient like that, you'll have to take an ECG to see if the patient has an atrial fibrillation or atrial flutter or atrial tachycardia. So what are the types of AF? So when you diagnose a patient with an AF for the first time, what is your first diagnosed AF? Then you have something called paroxysmal AF. That is, you have a patient and your patient develops an AF, and that AF terminates either spontaneously or with an intervention within 7 days. That is your paroxysmal AF. And what is persistent AF? AF that is more than 7 days to less than 1 year. And what is long-standing persistent AF? AF more than 1 year. So in these kinds of AF, you can go in for a rhythm control strategy. What if your patient has a permanent AF? That is, your patient has like in your later session you'll go and look into something called substrate severity. So your patient has LA remodeling, scar, a lot of scar in his myocardium and all that, and that all can contribute to this AF burden. So what you do is you accept the patient's AF and you go in for rate control strategies. So let's look into the scoring systems used in AF. You have a scoring system for assessing the true risk of stroke. That is a Chadwick. Then for symptom severity, you have an EHRA questionnaire. To assess your substrate severity. That is how much scar tissue how much of your myocardium is scarred. You can assess that either via cardiac MRI, transesophageal echo, transthoracic echo, or CT. So in assessing your substrate severity, you should look into your anatomy, the functional aspect, the structure, and the presence or absence of an LA or an left atrium or left atrial appendage clot or thrombus detection. So all of your 4 parameters, that is your anatomy, functional status, structure, and presence or absence of thrombus in your left atrium or left atrial appendage, all this can be assessed with cardiac MRI. hope you all have understood.